Welcome to Health Affairs from A to Z. This is our program that's really about you. It's all about you. We are here to help you as a healthcare consumer to feel empowered and to have more knowledge and more capability to take care of yourself. I'm Dr. Nancy Valentine, PhD and RN, and my role at the University of Illinois College of Nursing is both professor and associate dean, particularly in the areas of health practices. And we have a wonderful guest who is returning with us today, Dr. Marsha Snyder. And Marsha is also a PhD and registered nurse. And her role at the College of Nursing is also a professor, and she is working as the director of a program that is training nurses to be advanced practice nurses in psychiatric mental health practice. So today we're going to have part 2 of her program, PTSD, do you ever grow out of it? So that's post-traumatic stress disorder. Do you ever grow out of it? So welcome back, Marsha.
Thank you for having me.
We're delighted. We're delighted. The reason we're having part 2 is that we could hardly just get through the basics in part 1. So you can also access that on the CAN TV program if you'd like to see part 1 rather. But to just recap briefly, tell us, Marsha, what post-traumatic stress syndrome is in a few sentences.
Right. Post-traumatic stress disorder is a disorder, it's a DSM disorder, a mental health problem, that the individual has intrusive thoughts, has avoidance behaviors, changes in cognition and mood, and they're much more aroused and reactive to their environment. So they have flashbacks, and it's a disorder of the brain.
Right. So I think that's one of the things that we really made that point in our earlier program, is that this is not something that you just dream up on your own. That is actually a physiological change that has occurred in your brain as a result of some very traumatic experience that has happened to you. So give us an idea of the kind of traumas that people often wind up with, PTSD.
Well, the traumas can vary from one of the major ones that we don't think about very often are car accidents. That people who have traumatic experiences in car accidents, and one gentleman that I interviewed, he had bought a brand new car. He was very excited about his brand new car, took it out for a drive with a friend, and it was late at night, and he drove the car into a ravine. Wow. And he said that the thing that, he had been beaten up on the street, broke both of his knees, but this experience was so traumatic for him because he felt this loss of control. And I think that that's the issue, is that you have no control over the event. And it causes such trauma that he just could not recover from it.
Right. Not
to mention the financial issues, resulting from the loss of his car. But, but car accidents, certainly when we think about our veterans, they are certainly exposed to trauma out on the front lines. People who have been sexually abused, any kind of violence, and it's very personal. So where each of us are different in terms of our psychological makeup. So it varies in terms of how we respond to stress and trauma. So what might be traumatic for you may not be for me.
That's a very interesting point. And I think one of the points that we really want to invite you as listeners is that this is really not related to just simply war experiences. That's really when we usually hear about PTSD. It's really around our veteran population. And yes, that's very important. And certainly we have learned a lot from VA care in terms of how to most effectively help all people. But this is really about the everyday person and everyday life of these events, and I think that was a really excellent point that Marsha just made, and that is what happens to one person may be very different in terms of the experience of another. So it's not a one-size-fits-all disorder. It's not something that you can just have a blood test, for instance, and you have problem A or problem B based on that result. This is very much a lived experience and something that is incredibly personal. And what we really want to get into today is, as you age, what happens? Does this go away? Does it get worse? So I think what Marsha would like to tell us about now is what are the different groups that have this problem, and can we see differences across the age spectrum? So Marsha, just give us an overview of how that works.
Okay, so we have this graphic depiction here, and this is from the Department of DMH, and they have collected information. And what we don't have information particularly on women, although women seem to be more affected by PTSD than men. But when you look at the ages, the largest proportion of people affected are the age group of 45 to 59. And what we know is that once, if you've been affected by a traumatic experience, like this gentleman in a car accident, people then present with a lot of depression. And so that gets confounded with our over 60. So while this number seems low, it actually is probably quite high, because when we think about the numbers of people over 60 who are depressed, that number is very high. So that they may present with depression, but in fact what's underneath it is PTSD.
Okay, so let's just figure out this graph. So from the 18 to 29 number, 6.3% of the population are reporting that they've had a traumatic event for which they're having these ongoing problems.
Exactly.
Okay. And then that number goes up somewhat to 8.2%, 30 to 44 years old, and then again from 45 to 59. But tell us again about the drop-off in this number. Is it because people are not identifying they just say, I'm depressed, I feel bad. I feel bad.
But the trauma may have occurred during this 45 to 59 year range. The other thing that research is showing, and it's being accumulated right now, is that trauma is something that's cumulative. So that, one-time trauma is one thing, but it's this cumulative effect, so that someone who may be affected at 18 and then later at 30 and then at 50, and by the time they're 60, they have less resources available to deal with this later life kinds of trauma.
Okay.
Not to mention that, of course, we have some of the changes that we see with the aging, retirement. So we have more time on our hands to reflect on our lives, and of course then we start to think, and that gets us into trouble.
So sometimes this could be a sort of somewhat of a delayed reaction. Not that people haven't been reacting all along, but they haven't really focused on it.
Exactly.
So when you have this time on your hands, as you're saying, people then start to really reminisce and think back on it. So what happens? What's a typical kind of scenario?
Well, the scenario is that then the person begins to turn up in primary care with depression and medical problems. And there's a high comorbidity with depression. And certainly substance use is again, another comorbid kind of activity that occurs. But we see a lot of medical problems associated with PTSD because people are not sleeping. And we know with lack of sleep, we have cardiac problems, hypertension.
So let's take a pause and just think about that. First of all, we do invite you to call in if you have any particular questions, if you know someone that has this problem, or if you've had some of your own experiences that you would like to share, things that you would like to know more about. We're certainly a resource to you on this show. But the profile of people is that when someone is just presenting to their doctor, their provider, their nurse practitioner, and saying they're depressed, I think what we're hearing is that it's like, what is causing this?
What's behind it?
Right, what's behind it? What has never been really taken care of previously that really needs to finally be assessed and have some intervention at that time? So tell us what you're seeing. What are some of the symptoms? Let's go through our symptom list here.
Maybe we can enlarge that a little bit.
Yeah, we can. We may have to.
The first one is these intrusive thoughts.
Okay.
So we tend to think that, with PTSD, it's the flashbacks. People are having flashbacks, but that's not necessarily the total story, because a person may not have flashbacks, but they could have this involuntary recurrent memories, traumatic nightmares. And so I had a woman, now she was 72, presented to her primary care physician with depression, and she had diabetes, and referred to me. And after we spent some time talking, it turned out she had been raped as a young woman. And had not shared this with anyone, certainly did not share this with her mother. She had two very close confidants that they knew what had happened to her, and they had since passed. So she didn't have anyone else to talk to. And so in talking about this, it became clear that that was what was behind some of her depression, and that she was trying to just deal with this. She couldn't sleep at night because of these traumatic nightmares.
Right. So that certainly, so it took her till she was 72 to finally really deal with it.
Yes, to get some help.
Okay.
To get some help. Then we have the avoidance behaviors, where the person will just try to avoid any kind of thoughts, feelings, people's places, and this is where work is very effective. People, when they're working, they can, really drown out some of this. I have a guy who, he works heavy construction, and so he's able to manage his feelings because he's avoiding this. And my 72-year-old, she was no longer working, so this was not available to her. What some people will do is then turn to drugs and alcohol. So that, then you see this high use of other methods to avoid some of this feeling.
So the avoidance is really to help people cope with the
Right.
very negative feelings that they're experiencing.
Exactly. And then, of course, we have some changes in cognition and mood.
Now explain what that means. Not
Well-
everybody knows what that big word cognition means.
Well, it's how you think about the world and how you think about yourself. So a lot
Okay.
of these negative beliefs about the self and the world, for instance, the fellow who drove his car into the ravine, he felt like he should have known. It's all the should haves. If I only had known, if I could have, which he didn't know that was along the road.
It was an accident.
Yes,
Right.
he couldn't. And so there's all this distorted blame, persistent fear and horror. He couldn't drive. I mean, he could hardly be, in a car. And then the person begins to withdraw, and they feel alienated, isolated. And of course, in the case of our older person, they're retired. They lose their friends, and so their social network, which can be very supportive, is missing.
Right.
So you don't have that to fall back on.
All right. And then the last
Last one.
category is
This increased arousal or reactivity, so little, loud noises, anything that will trigger a remembrance of that incident, causes the person to be, hypervigilant. What we see primarily, though, in older people is this irritability and aggressiveness, the sleep problems, the inability to concentrate. And these get mixed up then with depression, because
Right.
in depression, of course, we have problems with concentration, sleep, and then irritability.
right.
And so they're misdiagnosed.
Well, very good. I think we have a caller who would like to ask us something. You're on.
Yes, I have a question. Would a midlife crisis, would that be something that could be a form of a traumatic event? Because I know that it can cause depression. People who think they need to make a career change maybe don't have enough time as they thought they would have because of family obligations and the like. And I know that in terms of other family members, of mine, that it's something that it's changed them.
Okay, that's a very good question. What's the difference between having a midlife crisis, which is a change process having to do with your stage of life, versus having a PTSD reaction? That's a good question.
Well, I think it's how the person defines that experience and what resources they have to deal with that. I mean, it's the same, if we have a change in terms of retirement. Not everyone who retires has a bad outcome. And so I don't know in terms of your family members. I think, it would be worth certainly having it assessed. But I think in terms of looking at assessment, we might look at these questions. And this is what we use. And it's a 4-question
So to answer,
question.
all right, we're gonna zoom this back down.
Yeah. Okay.
So caller, think about this as you're asking us this question. This is the kind of thing that you could use as a differentiator.
Has the person talked about having nightmares or having thoughts about this incident when they would not want to be thinking about it? Have they tried hard to or go out of their way in terms of situations, avoiding these situations that might remind them? It's not a midlife crisis isn't really a situation or an event. It's an event, but it's a personal kind of event. When we think about traumatic events, those are experiences that we don't have control over. Being constantly on guard and watchful, feeling numb or detached.
Right. So I think one of the ways to answer that question is that everybody goes through some kind of midlife crisis of change. And some of it is related to feeling somewhat out of control,
Right.
but it's really more around the here and now. Like, what am I going to do with my life? How am I going to make that next step? Maybe I won't have the choices that I thought I was going to have. Maybe I'm feeling sad about the fact that I'm aging. It could be any of those. The difference here is that this is a event that has occurred previously, and that your circumstances have changed so that you become very, very focused in some way or another on that past event. And it is causing all of these symptoms, which I think is different, clearly, than just going through a midlife crisis. Now, what I think I'm hearing Dr. Snyder say is that a person could mask this by saying, maybe I'm having a midlife crisis, but a good therapist or a good listener or a good family member
Exactly.
really having a deeper conversation could find out that it's really not a midlife crisis per se. It's a crisis having to do with something that happened previously. Hopefully that helps to help you differentiate. So I think we have another caller. Caller, you're on.
No, I guess not.
Okay. All right. Well, let's keep talking about. I like this list in terms of people being able to do some self-diagnosis. In terms of, if you think you have any of these, have you had nightmares, recurring thoughts? You're trying not to think. You're going out of your way to like sort of suppress a certain event, or it keeps coming back into your mind over and over again, where it's very hard to suppress
Right.
it. You're just on edge, and you're feeling detached. You just are really not yourself. So if you really feel, okay, I sort of fit that profile, what should people do?
Well, I think they need to see their primary care physician as a starter, and talk about what's going on with them, and take a look at it. Are there some other problems that are being associated with some of these feelings,
Right.
like depression, like substance use.
Right.
Again, people are smoking, using alcohol
Right.
as ways to cope.
One of the things that you really have to keep in mind is that you want to be going to a good treater, whether it's a physician, a nurse practitioner, a PA. Your team of people are aware of these problems. Some are better at diagnosing these things than others in terms of being more tuned in. So that's part of why we are having this program, so that you can come armed with some information. You don't have to sit in an office with your nurse practitioner, for instance, and have them sort of guess what's wrong with you. You can really volunteer that if you have any knowledge of something that has been bothering you, feel
Yes.
really empowered to bring that up, so that you can use your time in that meeting to really get some help, because then they have a better idea of really how to help you. So part of the techniques that we're going to talk about now are, what do people do to help you? I mean, what are some of those things that you can either do yourself or your treatment team can help you with?
Right, and which do not involve alcohol or other substances. So we have these grounding techniques, which are really very simple. One is to just count. When you're feeling a little bit, distressed, counting, starting at 1 and going to 100, or sitting around and trying to describe your environment in detail. It keeps you in the room.
Right.
The idea is not to drift in terms of these traumatic experiences in your head. Doing the alphabet backwards and forwards, playing a game of categories like naming breeds of dogs, TV shows. Or we can do physical grounding, which is running some cold water on your hands, touching objects in your environment, jumping up and down. This is where exercise is very important and can be very helpful. Holding a particular object that is comforting. And then we have soothing grounding, thinking of favorites, your favorite places, maybe a favorite vacation, a favorite song, a coping statement, such as it's uncomfortable but not life-threatening. Even though, we're feeling really stressed and unsafe, that we're not in an unsafe environment. And then plan for something safe.
So tell us how this works. Okay, let's take mental grounding, for
Okay.
instance. So are you suggesting that if a person feels like they're very, very stressed, they should actually start doing some of these things?
They should do something, yes.
And what does that do to help them?
It helps to distract, it helps to keep you in the room as opposed to drifting and starting to think about the event that is causing you all this distress. It doesn't solve the problem. It just buys you some time to get control over yourself.
Right.
And recognize where you're at. You're
Right.
not in the ravine with the car.
Right. So it's a chance to sort of regroup with your own thoughts and feelings.
Right, right.
How about the idea of exercise? Tell us a little bit more about that.
Exercise is great because, of course, when you're exercising, you really are focused on the physical activity.
Mm-hmm.
You know, I mean, I always say to people, take a walk, because, of course, if you're walking in the street, you have to be aware of where you're at, where
Right.
you're putting your foot, and so you are then in the here and now as opposed to in the past or in the future worrying about, you know, what's going to happen to me or how's
Right.
this going to go.
Right. We welcome any of our listeners to share any techniques that they've used that they feel like really have been very helpful
Right.
to them. But I think that what I hear in these various techniques is that this is different than running away from your problems. It's really at the point where you acknowledge, which is very healthy, that you have these problems and issues, and what you're doing is you're trying to self-soothe, is a term that's used. You're trying to calm yourself down because you know that this is going to happen to you. Instead of taking a frightening kind of response to it, you realize, I'm feeling very bad, I'm having this bad feeling, and this is what I'm going to do right now to help myself. That's a very different mindset than just like, I'm going to run away or I'm going to run to the gym just to escape. It's like you really sort of take those thoughtful steps to think through what you're doing. Does that make sense?
Yes, and it's also developing new pathways in your brain that are, again, a healthy pathway as opposed to the immediate response to this, a sound or,
Right.
an event.
Right. So you've taken us so far one step at a time. One is to really acknowledge and
Right.
identify this problem. Either you identify it yourself or you work with somebody to help
Exactly.
you to identify it. And then the second thing is to start looking at your life and how you live your life and having some interventions that really help.
Right.
Now, is medication an intervention?
Medication is certainly an intervention, and it can help, definitely not solve the problem, but it helps give you extra coping and a buffer,
Right.
and so that you can then move through your life
Right.
without overreacting.
Good. Okay. Let's talk about some of the non-medication approaches. What do you have here?
Okay, so we have, of course, avoid alcohol and drugs. Oh,
See,
this
that's the
doesn't-
first thing a lot of people jump to, right?
Absolutely. It's easy.
Yeah.
So that's the first one, to avoid that. And the next one, you know.
So are you saying, like, all right, let's just play this out.
Okay.
Instead of like reaching for a drink, you start counting to 100.
Right.
Okay. Right.
Exactly. You start counting to 100, or start looking at things in the room and
Okay.
identifying them. The next one, of course, is eating a healthy diet. You know, again, all of us talk about eating a healthy diet, but so many of us don't do this. So if you have a good breakfast and 3 meals a day, how many of you are actually having breakfast? I mean, let's think about it. Omega-3s play a vital role in our emotional health. So, I mean, it does go a long way in terms of fatty fish, flaxseed, walnuts, all of these things in your
Because
diet.
they're the foods that particularly have a lot of that vitamin omega
Yes,
3s.
and are protective.
Right.
And then limit the processed foods that you're eating. You know, eat real food. So avoid fried food and starches and sugars, which can exacerbate your mood swings and make things actually worse for you, and cause, you know, your energy to fluctuate and for you to feel bad.
So they may be referred to as comfort foods in some ways, but they're really not.
They're not.
No.
In the long run,
Right.
they're not. And the
Okay.
last one, of course, is, you know, sleep has come up any number of times in terms of this disorder. It really is to attend to your sleep. You know, guard against sleep deprivation, and then you'll feel a little bit better in terms of managing some of your anger and the irritability and
Right.
moodiness.
Right. Well, that sounds great. Do people really get cured of this?
Yes, they do.
Tell us some clinical stories of that, because one of the things that Marsha does is she does treat people on a regular basis. She has her own practice, so that would be, I think, something that maybe we're going to really have to. We're
Yeah.
going to have to wait for our next show.
Right, absolutely. But it is certainly a disorder that can be managed.
Yes,
It
that
can be
sounds
managed.
Great. That sounds great. Well, thank you very much for joining us.
Thank
and
you.
we'll hope to see you again soon.
All right.
Bye.
Bye-bye.